CHAUDHARY. He will today talk about dealing with complexities of brachial plexus. Dr. Roy, musculoskeletal radiologist at Oxford University Hospitals. You are most welcome.
Hello, everyone. First of all, thank you to Omar, Christian, and Rami for their excellent talks. I'm Roy. I work with Rami. Rami was my mentor. I did a fellowship with him. And thank you to the Egyptian Society of Radiology and Nuclear Medicine for having me here. So today I'll be giving my 2 nuggets about dealing with the complexities of brachial plexus. So here we go. I'll try my best to make it simple. So my memory of my anatomy exam was that your expectation from the professors was that you remember the brachial plexus in absolute clear detail, but it always ended up in my head as something of a mess like that. And then the question would be identify that nerve. And so I needed to come up with a way of how I can deal with brachial plexus pathologies. So I'll talk you through 3 cases, and I think that presents very well how you can deal with some of these issues. So I went on a BSSR and ESSR sponsored fellowship to Vienna, very close to Munich, where Christian is from. And there was a professor, Hannes Platzkumar, I worked with, and he was quite proficient in nerve imaging, and some of these cases are from there. So the first case was about this young girl, and if you just look at the video, she had injured her right wrist there, but on examination that they noticed that she couldn't really extend her left, which is the other side, and she had problem in also extending her fingers. So the case was loss of extension in the left hand, the other non-injured hand. So they wanted to investigate this further as to why she has this problem. So there's this very complex chart that Hannes introduced me to, which is the Weber's anatomical chart. And it looks very complex, but if you work through it, it becomes quite simple. And it's about, Weber was a proficient anatomist in the 16th century, and he charted all the nerves in the body, and this PDF is available online for anyone. But the way to think about any nerve issue is to look at the whole neural axis. So the first thing you think about, is there any central lesion? Is there anything in the brain or spinal cord? So that could be causing the problem. So they first started with an MRI brain, which was normal. The question was, could this be a spinal cord problem? So we started from the brain. We would look at the axis in the spine. And we did the cervical spine MRI. Again, that was normal. So then the question comes, it has to be somewhere in the brachial plexus, the peripheral nerves. So this is a zoomed image of the peripheral nerves here. So you have the C5 to T1. I'll see if I can point out with this. Yeah, so C5 to T1, and then the cords and the branches, and then these are the peripheral nerves and the 5 major nerves that come from the brachial plexus. So I'll work through this. So the idea with any peripheral lesion is to first start from distally. So on this side, you see these are most of the flexor compartment muscles. And here we have all the extensor compartment muscles in the forearm, so the supinator and the extensors. And here you see the pointer teres and all the flexor tendons of the forearm. So what we do is we start at distally, and we look at all these muscles, and see which muscles are atrophied. And any of these, if we can find any muscle that is atrophied, that will give us a clue. Okay, so we started with an elbow. So let's do an MRI elbow. And you see that the brachioradialis was atrophied and the supinator muscle was atrophied. Okay, so you go back to the chart, it will give you a clue. But we also caught that the triceps was also atrophied. Okay, so now I'll go back to the chart, and you see that the lesion has to be proximal to this level because we know that the triceps is also atrophied here. So if the lesion was here, the triceps will not be atrophied. So that gives us a clue that the lesion has to be either proximal to here, up till here, and we've already scanned the spinal cord. So it has to be somewhere from here till here, okay? So we know the triceps branch is coming off here. So our location goes from here till here. So anywhere in this vicinity is going to be the lesion. So we can target our imaging, either ultrasound or MRI, in this region, okay? But what we can also do is we can scan the deltoid and see whether the lesion could be further, we can localize the lesion further in this territory, okay? So we want to see what the deltoid is doing here. So we first, did a brachial plexus scan just as a scan, just to see whether there's a large lesion that we are missing out, but we couldn't find anything. So then we went with ultrasound just to have a look of the muscles of both sides and comparing. So we are looking at, we've already know that the supinator is atrophied. We already know that the brachioradialis is atrophied compared to the other side. We know that the triceps is atrophied, but we find that the deltoid is normal. So that, if you come back to this chart, again, the Weber chart, you see that these muscles are all involved here. So these are atrophied. But the deltoid here at the top in blue, that's normal. So, and that the nerve branch is coming off from here. So the lesion has to be located before the branch of the tricep, but after the branch of the deltoid. So in this, from the posterior cord till the branch of the tricep. So in this vicinity. So we have localized the lesion has to be in somewhere in that area. So what we did, we went with ultrasound, and the landmark for brachial plexus is the neurovascular bundle, is the subclavian artery and the subclavian vein, and the cords, the medial, the posterior, and the lateral cord surround this the vessels. So you can see, I'll scroll through this ultrasound, so you can see the lateral cord there, you can see the posterior cord there, and you can see the medial cord out here, okay? So I'll just mark it there. So lateral cord, the medial cord. But what we found that the posterior cord is looking very bulky compared to when we look at the other side. So that's the abnormal side. And when you look compared to the other side, it just looks abnormal and looks bulky. So we did a contrast-enhanced scan of the brachial plexus, and actually we found an enhancing lesion in the posterior cord. So we went ahead and did a biopsy of that, and it turned out to be an intraneural perineurioma. And the tumor was resected and the nerve construction was performed. So the tip from me is that you can think of brachial plexus in these terms, but you can also think of these in terms of the whole neural axis. And in isolation, if you think of brachial plexus, it can be slightly limiting. But if you think of the whole neural axis, it can be helpful to work out where the tumor is, or could be. So the brain, the spinal cord, and in evaluating the plexus, it can be a combination of MRI and ultrasound that may be needed. Okay, case 2. So this is a patient who the surgeon had evaluated this patient, and they'd done a carpal tunnel release, but the patient did not get any benefit from it. So it was a failed carpal tunnel release. So here we are showing the affected side, which is the left side, and comparatively the right side. And for those of you who do ultrasound, we are scanning the thenar region of the hand here. And the landmark for the thenar region is this central structure here, which is the flexor pollicis longus tendon. And I always find that useful because the muscles just superficial to the flexor pollicis longus and deep to it are innervated by different nerves. So the ones on the top are innervated by the median nerve, and the ones just below the flexor pollicis longus are innervated by the ulnar nerve. So here we can see that both are atrophied. So, and they're echogenic and they're atrophied. compared to the right side, where we can see just on top of the flexor pollicis longus, the muscle is preserved, and even below it's relatively preserved compared to the left side. So when you're seeing that, you're immediately thinking that it's a mixed nerve pathology, right? Because if it was just median nerve, you would just see the superficial muscles being affected. So whenever you see mixed nerve pathologies, go hunting for proximal lesions, because it's mixed nerve. And what we found, compared to this, the normal right side, and this is the left side, this irregular structure on the brachial plexus. So we did a contrast-enhanced MRI, and we found this enhancing lesion on the brachial plexus. And we went back and looked at some previous images and found that this patient had had the mastectomy with clips, and the diagnosis was a breast cancer metastasis. So my kind of learning from this case was that the pattern of muscle denervation can be very helpful in evaluating brachial plexus problems. So I'll just go through a quick overview of how I like to scan for brachial plexus pathology. So here I was talking about the anatomy. So the things in blue here are all supplied by median nerve. And all the muscles of the hand, the rest of them in red here are supplied by the ulnar nerve. So that's a very helpful clue. And here is the flexor pollicis longus. I'll show you a normal case. So you see this is the flexor pollicis longus. And when you scan with ultrasound, you see these muscle bellies very, very nicely. So this is a normal patient. And again, the one in red here is the median nerve, and this is the ulnar nerve. The other clue is when you scan the hand, most muscles of the hand, the intrinsic muscles of the hand, are supplied by the ulnar nerve, which on the next slide I'll show you will all be marked in yellow. So those are, again, helpful clue whether the ulnar nerve is involved. So, such as the lumbricals, the interossei. So you can all have a look at them, and if you just get used to it, it's very easy to. So apart from these two lumbricals, most of these muscles, the lumbricals, the palmar, and the palmar interossei, are supplied by the ulnar nerve, which is marked in yellow here. And also the interossei, the dorsal interossei, again, all marked with yellow, are supplied by the ulnar nerve. So these are helpful, and I'll show you in the case number 3 how they are useful. And then the forearm, the one muscle that I find very useful is the pronator quadratus muscle, which is a band of muscle. It's a very easily identifiable muscle. So when you scan the forearm, I'm just coming from proximal to distal, and you see this muscle here crossing over distal radius and ulna, and that's the pronator quadratus supplied by the median nerve. So again, if I use these muscles as a clue of which muscle can be, which nerve has been involved. And then just generally looking at the flexors in the forearm and the extensors as well. And as we come here, you can just look at the extensors as a whole and just see which muscles, so they can always give you important clues. So this is an alternative way of how you can approach ultrasound for nerve imaging. Case number 3, again, so hopefully now it will be a little bit more clearer. So if you see, this is the normal side, and you see the muscle bellies of the dorsal interossei are maintained. Compared to the affected side here, you can see I'll show you this here. So this is a little bit more echogenic and a little bit more atrophy than the other side. So the dorsal interossei are involved, which is the ulnar nerve distribution. While here, if you look at the pronator quadratus on the normal side, normal bulk, normal echotexture. When you come to the affected side, it's echogenic and it's atrophied. So again, we have a median nerve problem because of pronator quadratus, and we have a dorsal interossei, which is an ulnar nerve problem. So it's a mixed nerve problem. So when that happens, again, start looking proximally for any problem. So we had an X-ray, thankfully, which showed a cervical rib. And there was compression of the brachial plexus, and this is an eponymous name for this ligament, which is the Zucker-Kandel ligament compressing on the brachial plexus. So that's my learning from these 3 cases, and hopefully you found it useful. So in summary, You know, a combination of ultrasound and MRI may be needed for complete workup. Anatomical nerve charts and pattern of muscle denervation can help localize a lesion. And mixed nerve involvement should necessitate a search for proximal lesions. And this is just a little bit of background about me who don't know me on the international MSK conference circuit. As I said, I've recently been appointed as a consultant by Rami. Completed a MSc at Oxford as well. I did a fellowship at Vienna, very close to Germany, and then I was an anatomy demonstrator before. So that's about me. And just I've recently got married last week, and I've been on a trip to Egypt, and I've enjoyed your beautiful country. It's absolutely wonderful, great people, great food. And these are some of the pictures. I just thought I'll share it with you. And this is my wife. We went to the Abu Simbel temple, and this is the sunset at River Nile. Absolutely gorgeous. The Hatshepsut temple. It was great that Egyptians actually knew everything. That's what I actually came to the conclusion. They knew about everything about the world before anyone else. So, it's great to be here. And this finally, when I was in Vienna learning about all this stuff, there was this street artist who used to play this. I don't know whether it will come, the music, but he used to play this really nice, and this is a 10-second clip. I don't think the audio will come, but anyway, I really liked how he used to play, and and I went on, and I used to go on a run, and always used to go and listen to him, and it was a great experience in Vienna. It's a beautiful city as well, and that's it. And if you have any questions, please free to ask now, or you could email me alternatively later. Thank you.
Yeah, thank you, Dr. Roy. Thank you, Dr. Roy, for the nice presentation. It's about, the most important thing in such a lecture is how to think about, the clinical scenario, and in order to combine it with the MRI or with the imaging modalities. Any questions, please?
It was me, I was talking. Anyway, thank you. Thank you, Dr. Roy, for this lovely presentation.
Thank you.
I will ask you a question which happened to me. I'm a patient and a doctor too about brachial plexus abnormalities and problems. I had a surgery on my right side because of brachial plexus entrapment. Problem is nobody knew what's the problem. I had pains in my arm for years, radicular pain. I couldn't hold a pen, and sometimes episodes of cyanosis due to vasoconstriction of vessels. And everybody saw me until I went to France to a very esteemed doctor who used to do surgery for Diana's patients, Princess Diana. And he's called John Merrill. You know him? I don't know if you have heard of him.
I personally don't know him.
It's his profession, hand and arm surgery, and
Okay.
brachial plexus problems, and he do microsurgery and this.
Sure.
So he opened my neck because he didn't know, but he thought 90% it comes from here, not from my brain, not from my hand, because they did me a carpal tunnel. You know what they found? They did me an MRI, they did me a color Doppler, ultrasound, and they couldn't reach anything.
Yeah.
I had a congenital anomaly, scalenus anticus.
Mm-hmm. Scalenus anterior.
Scalenus anticus.
Yeah.
Called anticus because it's an antique muscle,
Yeah.
and it's not problem. And it hypertrophied tremendously because I was a weightlifter at the time, and I had a fibrous strip which it did not. It was not seen by MRI. They didn't know it, and the scar because I was a horse rider too, and I jumped and I fell over my neck and I had a scar. So the problem is with the fibrosis and with the muscle compression. How could we diagnose that? There is no tumors or anything, just muscle compression. And I had it bilaterally, but I didn't have the pain on the left side.
Yeah.
I had it only on one side.
Yeah.
And both muscles were the same thickness, everything. But why this one was overt and it was showing neurological or radicular symptoms and the other one not. He didn't know even.
Yeah.
But he told me that next time you will come and he will cut me the other scalenus anticus. Of course, I didn't do that. He only did resection of this side, on this side. Could you have an explanation for that? Because many patients may fall into this brachial plexus hidden.
Yeah, no, absolutely. I completely see where you're coming from. Actually, in Vancouver, when I was doing a fellowship, there would be a vast subset of patients where even when we try all of these imaging modalities, we still cannot reach a definitive diagnosis in terms of, you know, a muscle atrophy or any extrinsic compressive lesion. And practice varies differently across the world in these situations. And what, you know, a lot of people used to think that they would take off the first rib and, you know, increase the space, you know, in the outlet. That, you know, that has, again, questionable benefit in the literature. Like you said, accessory muscles, we routinely would scan with ultrasound. Actually, you can see the exits of the cervical nerve roots and a lot of people actually inject cervical nerve roots under ultrasound rather than doing them under fluoro or CT. And you can actually see the nerve roots coming out very easily. If you have a skilled operator, and again, I only saw them in Vienna when I was working with this professor, and then in Vancouver, again, there were a subset of patients who had this. And dynamically assessing these patients can sometimes give you a clue. But I mean, that's the best explanation I have in terms of if you can't find anything radiologically, even with skilled operators, then I suppose surgical exploration would be the next step. Is that what your question was, or?
Which is, it's not explained, they have to do surgery.
Yeah.
But he did a laparoscopy, he didn't see anything, he had to cut me all the way.
Yeah.
And explore what's going on there.
Yeah.
And then he found this. But many patients, we have them here.
Yeah.
They are suffering of the same thing.
Yeah.
Because of, most of them are weightlifters. Most
Yeah.
of them.
Yeah.
Because of the hypertrophy of muscles and
Yeah.
narrowing of the
Yeah.
of the brachial plexus.
Yeah. Yeah, and I completely agree. And when we do this, the sagittal imaging for brachial plexus, and you can see that triangle from which the brachial plexus, the nerve roots come off, and I suspect in patients who have either an accessory muscle or who have hypertrophy of this, scalenus, the brachial plexus comes between the scalenus anterior and scalenus medius, right? Yes. And comes out from there.
Do you have a picture? Do you have a picture of the nerve brachial plexus by ultrasound?
Yeah.
And
yeah.
we could see it by high resolution ultrasounds. Do you have a picture of that?
Yeah, I can show it to you. What I'll do is,
excuse me, we are running out of time.
I'll show you an image
so
of
sorry.
of the ultrasound images. I have it in another slide.
I would like to see it with the new set.
Perfect.
Thank you.
Yeah, thank you, Dr. Roy. Right now, I will introduce my friend, Dr. Khalid Matrawi. He will talk about pediatric bone tumors.